Great. Well, we have a lot of questions that have come in, which is great. So I'm going to try to lump some of them together a little bit, and feel free to jump in as you do. One of them has to do with specific interventions that are happening inside a global model. And, this is a little bit of the discussion around return on investment, in the sense that sometimes people think of these one, thing at a time and what's the return on investment. But I'm going to ask it more generally. You have a great set of incentives. It could be within Medicaid, at an ACO level, at a hospital global budget level. And then you have something that you think is going to help. It could be an innovative community health worker program. It could be a special way to, coordinate care or teach doctors and nurses something, or whatever it particularly is. How important is it to know that unique interventions, contribution to success for health? And how does the overall system, support, the innovation in those kinds of things underneath the umbrella of a strong, either global set of incentives for health? How do you look at those individual things? How do you know whether they're working, when it's at a whole system level and you're trying to figure out what the right things to invest in are? Donna, maybe?
So I think in terms of implementation, some of the DSRIP programs around the country had specific interventions that were that you could choose from, and that they would measure and those programs measured the results. The Maryland program was not launched that way. So each the health system had the ability to invest in the way that they wanted to invest to achieve the results. And we focused on holding them accountable through the outcome incentive programs. So if we used very strong outcome incentive programs for reducing readmissions, and folks faced penalties and rewards based on getting the readmissions down. So the health systems tend to work together to figure out what are the strategies that are working in Maryland or elsewhere, and then stealing shamelessly and copying what's working is really kind of the way people would decide. The outcome is whether you were getting there in terms of the reduction. So I would say there was a lot of innovation. There were a lot of stakeholder meetings to get people to talk to each other about what they were going to do and what they were doing. We did have some grants that we put out to allow people to allow the health systems to bid on innovation approaches. So there were multiple approaches to try to get that out of the box. In terms of measurement, there is no way that you can measure one innovation at a time and its impact. It's really a whole series of things that are going on. Medication reconciliation, home visits, the focus on chronic conditions, building better predictive models. I mean, there were so many things going on, it would be impossible. And even if you're looking at primary care and trying to separate that from what the hospitals do, it's all building on top of each other.
So I partly hear you saying that you don't expect like quite the same ROI calculation as maybe some other places are thinking, because there's no other source of funding unless you can prove that it saves money. Here, you know the incentives for the system, and you're basically, designing outcome metrics that are very focused on what the different initiatives are, and that's good enough in that way. I don't know.
Yes, and CMS has very specific outcomes measurement too. So it's CMMI and the state create their outcome incentives, and then we drive them down to the providers.
Ina, how do you think about this question? One of the questions is, how much do you attribute savings to a particular community health worker model versus the overall, goal?
It's really such a great question when we're working in this broader system where we're trying to create the environment and the incentives for the actors in the system to work within. But it does come to bear, for the state, we do have accountability to our federal partners. We do have Medicaid investments in particular that we're making in system change. And we also, as partners as partners in the system with our own not our own, but with as shepherds of the state population health goals, for instance, as shepherds and stewards of our patient-centered medical home, we do have interest in knowing where an intervention should be scaled or where we should apply the tools that we have to see that intervention scaled more broadly. However, there's a tension point because we don't have the ability to rapidly evaluate every single piece of innovation that we're seeing unfold because we are doing things differently. It's something that we're looking at, trying to do more of, how we introduce more of that rapid cycle evaluation into our design of our program, but it's not happening today that we're capturing it all. However, there are particular areas where we do need to capture the results, especially when we're using particular, I would say, federal funding streams to do so.
So it sounds like that this is not, it depends a little bit on the situation for the intervention, how it may be looked at, that some things may be judged on their direct outcomes on the population-wide measures, and others there may be a more discrete technical evaluation that's actually done. Cindy, how do you think about this for the Medicaid program and what is, paid for? You talked about the flexibility that Medicaid has. What's the, responsibility? What kind of data do you think needs to back up? Like, you hear about somebody buying air conditioners, to use your example. Do they need to show that it actually did reduce it? Is it enough that they have the incentive to reduce admissions and we'll let them do that? How do you think about, particularly as things go a little bit outside the usual lines, the requirements around data and outcomes?
Yeah. Well, and let me just say we've evolved a lot. I remember years ago when I was at CMS and we were implementing health homes. And the whole idea of health homes was to have a relationship and work with the person and move away from volume. And everybody at CMS was very nervous. Are we going to pay a health home not based on how many widgets, not based on how many visits, right? And we said, yeah, you're not. And really trust that it's going in a different model. So you've got to look at different kinds of data to see, did over time, did health seem to be improved? Over time, was, utilization of important services squeezed? But you got to trust a little bit the incentives, I think, and the instincts. I have a friend who says, that we really don't have good data right now to show that releasing a pregnant woman with other chronic illnesses onto the streets if she's homeless is efficacious in terms of her health, but really seems like that's the right thing to do. So I think the whole concept of freeing ourselves up to make some of those decisions with the guardrails that Ina and Donna have talked about. I just want to flag one thing because we can't lose sight of the importance of equity through all of this, and I know nobody here does. But our data on our race and ethnicity data is not great. And if we want to make sure that we are not underserving and we are properly moving along the goals of reducing disparities, we really do have to sharpen our focus on making sure we're collecting the data that we need to at least check all populations.
That's a great point. And I think it also reflects one of the other advantages of these large models, which is you can set statewide policies on data. You can collect data for everyone, and that allows a lot of different flexibility for different kinds of assessments of outcome and evaluation at much lower cost than if you're hiring a research team to track people through every possible intervention point that they might have. And so one of the opportunities and obligations of statewide models is to really do data well, including for for equity. But it's important. If you're aligned for health, you can really learn a lot about what generates health and where investments are. Since we're talking really big, and I know we have 4 more minutes, I think, Dr. Davis, I was told we had extended till 3:25. I'm going to ask one question that's come up, several different variations here for quick answer. It's not an easy one, but has to do with as we're thinking big and globally, and we're thinking about other systems that might come in contact with the healthcare system. Housing's been mentioned. Oftentimes education is mentioned. Is the goal here to really manage the healthcare dollars well and drive attention to those other systems? Is the goal to shift healthcare dollars to other systems? Is the goal to save money in other systems and move it into healthcare? How do you think about the relationship when we're talking about big models, state level, between healthcare and other systems that obviously have so much to do with producing health? This is asked by my fam as the question of, do we need more money in healthcare? Is there enough money in healthcare? But there's another way to look at that, which is, or should we be spending money in other places? So how do you think about that? How does this fit into that bigger conversation now that we're at this statewide level?
I'll jump in on that, and hopefully others will say something about it. I think it's all of the above, actually. I think that there are cross-sector savings that can be achieved when healthcare steps to the plate. I'm thinking about a lot of initiatives that state Medicaid programs are looking at, or a lot of state Medicaid programs are looking at, for example, justice-involved populations.
Yeah, sure.
Right? And how to make sure when people are transitioning out of jails or prisons that they have care, coverage, medications right from the jump, care coordination, and other supports, right? And that should, we think, not only improve their health, but probably lower the justice costs. When I think about some of these low cost kids, right? I can see improvements in or savings in child welfare and the Department of Education budgets, right? So I think pooling some contributions across sectors is important if we're going to get the interventions that we need that will help help people and help save dollars. I also think that we need some more investments, as I noted. Certainly, I think we do on the housing front. So we need some additional investments. And then within healthcare itself, I think we need to right size it. We're just spending a lot over here and not enough over there. So whether that overall means that we can squeeze a lot of money out of the healthcare system to go somewhere else, or whether that means we need to, because I see Maya's question too, goes to HCBS. We certainly have underutilization in terms of paying for people who need long-term services and supports. But we definitely spend too much in some areas in our healthcare system and not enough on others.
Great, thanks. Any quick thoughts, Donna?
In the second 5 years of the model, Maryland is doing some shifts of money outside of the traditional healthcare through the global budgets of when a hospital's cost per case gets higher than it maybe should be, and it's per capita cost because it's retained a lot of revenue from reduction in volumes. Some of that money is being shifted over to to some of the things that Cindy has talked about that need to have investment dollars. And so we had a hospital convert to an outpatient facility, and the savings from a big chunk of the savings from that was plowed back into alternative approaches relative to social determinants, et cetera. And so trying to keep the savings going back into that community to address social determinants.
Great, thank you. Ina, last word.
From time to time in Vermont, we've explored a budget for health, a statewide budget for health and what that would look like. And there are a couple of tension points that typically come up with that which are with a unified health budget. Does that mean medicalization of these other services? Does that mean that you're giving them over to the healthcare system. And conversely, in the healthcare system, does that mean we're somehow responsible for all of these other outcomes, such as, you know, education, recidivism? Does that then become something we're accountable to and judged on? So I think it's certainly it's an area that's been very fun to explore. It's not without those tension points.
Great. Well, thank you all so much. And now we really appreciate this discussion at a very large level, the environmental level, you know, going from the individual clinical interaction up to big questions about how huge systems work together and create the environment for a lot of change for health. Thank you all so much for joining us.
Thank you, Josh, and thank you to the panelists again. This was really a fascinating panel, and they just keep getting better. So thank you all for continuing to be with us.